It's 4 p.m. Italian time, so it's time to say to everybody benvenuti, which in Italian indeed means welcome. Welcome with the image of the Italian pavilion that is made by the 3 reversed boats that are a metaphor of the journey we all are having around the world, and that hopefully soon will lead us indeed to the Universal Expo, where we will be able to gather together again in person with more than 190 countries. And you can see over here the fantastic pavilions of Russia, UK, and Spain. And we look forward for seeing all the other nations that indeed in this case are in representation of the 3 languages we will enjoy simultaneous translation in today, together also with international CME credits that will be provided to everyone. Simply write to the organizing secretary after the webinar, and remember then to choose the language you prefer. Remember that in whatever language you can make questions in the question and answer box, and not in the chat, in the question and answer box, and they will be answered by the speakers live if there will be time, and if not, in written form. I'd like to deeply thank all the ones who have joined this educational online journey that is leading indeed to the Universal Expo, where we will enjoy an in-person event during the winter meeting that will connect experts to properly inform patients in a fake news free communication, in particular in the venous and lymphatic ward. Deeply thank to all the ones who have already achieved this teamwork during the Achieve project, during the VW in China, and now on the important topic of pelvic venous disorders that we know is still considered a forgotten disease, for which we are looking forward for a multi-specialty teamwork. And for this reason, we chose to get engaged with one of the biggest experts in the area, Professor Zaza Lazarashvili from Georgia, and all the prestigious Georgian Association of Angiologists and Vascular Surgeons, who we deeply thank for the teamwork, as we deeply thank the previous Sunday Stellar faculty who joined us. And as we deeply thank the stellar faculty of today, we will introduce, of course, them one by one. I'd like to give a special thank to Professor Wittens and Professor Altarazi for providing the preparatory material to today's webinar, and also to Professor Urbanek, who sent his material. And I'd like to deeply thank, of course, the unbiased support of Alpha Sigma, who made this educational effort possible, in particular the Russian subsidiary for the Russian translation. As always, nothing would have been possible without a team I consider also family, so I'd like to pass the mic now to Professor Bottini.
Thank you, Sergio. Dear all, once again, thank you for being here with us on this educational project. And a special mention to Professor Lazarashvili, our colleague from Georgia and Latin America. I hope you will enjoy the outstanding scientific program.
Thank you so much, Oscar. Willie?
Thank you all. Good morning, good afternoon, good evening, and here we go again. 谢谢我们所有的中国同道们，请你有任何问题的时候，请在我们的 Q&A 向我们军官为您答复。谢谢。
Thank you so much, Willie, also for always interacting with the Chinese colleagues and friends. And now the mic, of course, to our project leader in this POP initiative, so Professor Zaza Lazarashvili. Salvatore?
Thank you, Sergio. Dear participants, dear faculty, today we start the second webinar, the Pelvic Venous Disorders online project, and take one step closer to Dubai 2022. At the same time, the high attendance rate, which was on last Sunday, and which exceeded 1,300 participants, clearly indicates the urgency of the problem. I hope today's webinar will be interesting and fruitful for you. And with this signal of gong, I declare today's webinar open.
Thank you so much for this traditional sign, and I have the traditional bracelet of Georgia, so I hope it will be a good Georgian and international journey. Another fundamental educational journey was the one done together with Latin America and Africa, thanks to Professor Taha, Bishara, Simkin, Carlos, and Bottini, of course. And as we did last week. We always open with a guest of honor that was from Egypt and was from the OBGYN ward. And the same we will do this time, flying all the way to North America, thanks to Professor Neil Kijani from Cornell University, who introduced to us a very important professional figure in the OBGYN ward from there. So Neil, if you'd like to introduce us our guest of honor.
Yeah, Sergio, thank you very much for the opportunity to speak, and to Oscar and Willie and Sergio, thanks again for highlighting the issue of pelvic venous disorders. This isn't something that's new, it's something that we've talked about for years, but many advances in our understanding, as highlighted by Dr. Ull's talk last week on anatomy, and Alex's talk on clinical presentations, and Zaza's talk on the actual precise definition of what this disease is, has opened a lot of potential vistas for us to expand the ability to help patients. One of our challenges, though, is our data is still not very robust. And you'll hear that from Dr. Lehrman. Dr. Lehrman holds a medical degree and a PhD from Harvard University. He is a biostatistician and epidemiologist, as well as a renowned gynecologist. And he's been a great partner in this project, but as you'll hear from his comments, there's still a lot of work for us to do. So with that said, thank you for having both of us speak today.
Thank you so much, Professor Kijani, and here is the intro.
Thank you, Dr. Giannassini, the Georgian Association of Angiologists and Vascular Surgeons, and the VWIN Foundation for inviting me to open this session of the meeting. Greetings from the USA, where I serve as Dean of the Virginia Tech Carilion School of Medicine and as professor in the Department of Obstetrics and Gynecology. My clinical niche and our specialty has been the comprehensive evaluation and multidisciplinary treatment of chronic pelvic pain in women. Over the past several years, I have supported the American College of Obstetricians and Gynecologists, ACOG, in their collaborations with the American College of Radiology and vascular specialty community to identify the role of pelvic venous disorders in chronic pelvic pain. When I was co-authoring the ACOG Practice Bulletin, there were so many gaps in the scientific literature that we could not offer helpful guidance regarding the role of pelvic venous disorders in chronic pelvic pain. The work you are doing is incredibly important. Through recent collaborations with the vascular community, we are on our way to answering these important questions. In the coming years, we hope to have a much better understanding of how to identify which patients are likely to have a pelvic venous disorder contributing to their pain, so they can receive appropriate treatment. Thank you again for this honor.
And we deeply thank Professor Kijani and Professor Lehrman for favoring the teamwork. We really look forward with the multi-specialty approach. And now it's time to get into the science. And what a better example than Professor Nikos Lapropoulos, our ultrasound eyes in the venous and lymphatic ward. So it's a huge honor and pleasure to give him the mic to talk to us about how to identify pelvic venous reflexes by ultrasound. Nikos?
Thank you, Sergio. Hi, everyone. In a cold Sunday morning in New York, when we talk about the evaluation of this system, we're looking for veins from the pelvic floor to the diaphragm that have multiple connections between the axial veins, the IVC, iliac, and pelvic and ovarian veins. There are obviously anatomic variations. There are collateral pathways in people with vein obstruction, reflex pathways, a connection to the lower extremity, and combined patterns of reflex and obstruction. Do not forget that I should avoid to use the name of syndromes, no pelvic congestion syndrome anymore, pelvic vein disorders, and no eponyms. And we should use, like we use for lower extremity, vein disease, reflux, obstruction, or both, has been emphasized in our paper, which is in press in the vascular surgery on the new classification. Now, who should be evaluated? Well, those who are having pain in the abdomen, flank, pelvis, and perineum, those with urinary frequency, hematuria, lower limb signs and symptoms associated with pelvic vein disease, and those undergoing follow-up of interventions. some of the patients we see are those atypical varicose veins, like you see in these pictures, in the inner thigh and perineum, in the gluteal area, and posterior medial thigh. And many patients present, although chronic pelvic pain, as you heard from Dr. Learman, and the evaluation by a gynecologist is necessary prior to any venous treatment. We produce a standardized protocol, which I'm going to discuss now, of how to address these disorders. Well, we look at the inferior vena cava, the iliac veins, the left renal vein, the gonadal veins, the peri and transuterine veins, the tributaries of the iliac, the pelvic floor, and the connection with the lower extremity veins. What we're looking for obstruction, reflux, flow patterns, anatomic variations, the diameters of the veins, use ultrasound to guide interventions and also to have a follow-up. And here are images that I drew on a patient with pelvic vein reflux, and this is the identical locations of the patient's skin of what we see. We start the examination with the inferior vena cava, and we look for obstruction, aplasia or hypoplasia or duplication. We look then to the left renal vein, the left ovarian vein, the right ovarian vein, and then we go to the periuterine veins and the pelvic floor. And these are the positions of the transducer for the locations of the IVC and iliac veins. Then you see here how we position the transducer to examine the left ovarian vein, proximally and distally, the ovarian plexus on the left and right side, and then we go about 10 centimeters below the umbilicus to see the transperiuterine veins. The exam is done with some inclination of the torso, but if it's not sufficient, then I'm going to show you later, we stand the patient up and do the examination for the perineum. And here is an examination of a patient that has reflux on the ovarian vein. Typically, this vein is dilated when there's a problem, and this vein touches the psoas muscle you see here. Unless the vein touches the psoas muscle, we don't call it ovarian vein. Usually, are veins with white tissue around, which are the mesenteric veins. They should not be confused with the ovarian. And because these people having lower BMI in general, the mesenteric veins are very close with the ovarian. And here you see a patient that has a dilation of the ovarian vein, and it's measured almost 9 millimeters. And the vein at the L4 usually is duplicated, or sometimes you can find even 5 veins. And both these veins have reflexes in here. But what you may notice, discuss, this is a spontaneous high volume reflux, which is, as we have described, is an indirect sign for left renal vein obstruction as the kidney empties into the left ovarian vein. And here you see the union of the right ovarian vein with the vena cava just below the entry of a right renal vein to the cava. And you see here a typical normal right ovarian vein with phasic flow, but here you see one with reflux as the vein has exactly the same color as the artery. But often we notice the right ovarian vein is dilated. It has no reflux. And here you see beautiful flow, it's augmented, diameters of 6 and 7.5 millimeters here. And the reason for this is because the right ovarian vein often receives the refluxing blood from the left ovarian vein, and therefore has a compensatory dilatation with augmented flow. Therefore, we should not treat veins based on a CAT scan showing a bigger diameter on the right. Using the diameter on the right side is an erroneous criterion and often unnecessarily treating people, that don't need such treatment. And here you see the connection on the left side between the the left ovarian vein and the left renal vein. And further down, we see periuterine veins are dilated more than 5 millimeters, you see, and multiple, and then dilated veins on the right side of the uterus with reflux. And then further down, on the same patient, reflux in the perineal and suprapubic veins. Here we use the standing position because it uses hydrostatic pressure. The Valsalva maneuver can be performed without any interference from the abdomen and the bowel. The veins is the largest diameter. The transperiuterine veins, distal tributaries of the iliac vein, and the connections with the pelvic floor and lower limbs can be easily seen. In fact, the distance are about 2 to 3 centimeters from the uterus, so the linear transducer is used 90% of the time. And you see here how it is directly from the perineum Then we look the saphenous vein and the connections, and then go to the middle of the saphenous vein to see the connections to the pelvis and then the valvular area. And here you see in this drawing the pelvic outlet, and you see the different windows. Most prominent one, the perineal, it's called the P, and then you go a little bit posterior to see the gluteal, and then you go a bit anterior to see the obturator, and then over the body the guinea. Here's an example of female patient, 35 years old, with 3 children, the bilateral extremely varicose veins, but the various veins are normal. Now, why I put this? Because using or tapping of the variant plexus, you can actually induce reflux like we use reflux in the saphenous and extremity. And the variant vein has 2 to 3 valves. And you see here, when you compress, right, blood goes backwards, and after there is no reflux. That means the ovarian valves hold, and that's not a reflux, that's a normal vein. But the same patient is reflux in the tributaries of the internal iliac vein, like you see here in multiple occasions, both of the curvilinear transducer through the abdomen and also the linear transducer through the perineum. You see it's long reflux. So often there are several patients that have reflux only the tributaries of the internal iliac, and the ovarian veins are not involved. And here you see reflux on the obturator vein, which looks like typically as a hook here, right? Both on the right and the left side, and having reflux. And then the saphenofemoral junction on a patient here, which is normal on the right side, but there is a reflux on the left side with multiple connections from the pelvic vein veins that they're refluxing. And here we see tributaries medial saphenofemoral junction, right, which are very close to the skin, and as you follow it up, they dive down into the pelvic area to connect the periguterine veins. And here you see typically reflux, which is really high velocity and prolonged, right? And this patient had multiple perineal veins both on the left and the right side. Here is another example of really big veins that you don't need ultrasound. You see, if you see the skin area here on the left posterior upper thigh, there are big varicoses that touch the skin basically here, and you can see by the physical exam. But if you continue with the ultrasound, both on the left and the right side, these veins enter the pelvis, right? They are very tortuous, dilated with a lot of reflux. And here you see on this video, using the curvilinear probe, reflux in peritransUterine veins. And you see here, a bit farther down, how the veins exit from the periguterine space and go close to the skin and meeting the veins that I saw you on the previous slide. See, on the static position, look how close is the distance, right, from the skin to these veins or to the uterus. Very easy exam. You can do it with a very little experience. And some people that come up with reflux, they often have obstruction, and this is an example of a patient has compression of the left renal vein, not nutcracker. We're going to abandon these terms. Obstruction left renal vein. You see here there is a narrow orthomesoderic angle, which is typical, less than 30 in such patients. And typically, but not always, the pre and post-stenotic vein diameter and velocities is the ratio of more than 5. They're often collateral development to bypass the obstruction, and often the flow is diverted to the left ovarian vein, and that's this high flow I showed you earlier because the kidney empties into the left ovarian vein. And here's an example of one of our technologies. It's totally asymptomatic. It's 22 years old with a BMI of 19.2. And you see the diameter at the area of the obstruction is 1.5 millimeters, and distal is 9 millimeters. And you see the jet with a high velocity, and the velocity is 8. You can see this patient doesn't need anything. He's just a skinny, young female with compression of the renal vein, has absolutely no signs and symptoms. Therefore, you don't treat, you don't touch the patient. And we found, us and others, there's a correlation between the pelvic venous disorders and body mass index. First, in the people with pelvic reflux, not all, but many patients, the BMI less than 25, and have now an ongoing study through 3 different centers demonstrating that the BMI of those having left renal vein obstruction is less than 23, and if you are a male, usually is less than 21. And in children, this actually is even lower. And here you see typical high flow pattern in a very dilated ovarian vein on the left with exactly the same color like the iliac artery. You see the spontaneous high volume flow indicating that the kidney drains into the left ovarian vein. And to finish, for the pelvic venous disorders, we look for reflux, obstruction, or both. You need to be familiar with the ovarian veins, the iliac veins, and the tributaries, the common femoral vein, and the connection to lower extremity veins. In our hands and many others, ultrasound is the diagnostic test of choice, but other tests like computer tomography and MR may be useful when there's suboptimal imaging or limited experience with ultrasound, or in some other occasions, if you look for better differential diagnosis. And with this, I'd like to invite everyone to our Venous Symposium, strongly collaborate with Sergio and the VWIN team in next April. And thank you, everybody.
And it is us deeply thanking you, Nikos, for your time and effort in allowing us to get started with such a top quality. And indeed, I recommend everybody to attend New York Venous Symposium. I define that symposium as something at least once in a lifetime everybody should attend to. And it is my pleasure now to fly on the way to Costa Rica. It's a double pleasure because the last time we were together in person before this crazy change of the world, it was with Nikos, it was with Dr. Lorena Grillo, a wonderful representative of the region and an exceptional professional. So Lorena, the mic is now for you to ask your expert question to Professor Labropoulos.
Thank you, Dr. Genesini and Dr. Labropoulos. My question is, in case of obturator vein reflux exiting the pelvic floor and concomitant SFJ reflux in lower extremity varicose veins, what would be the most appropriate treatment approach you suggest? And should be a staged approach?
To me and many others, it depends on the symptoms on the patient presentation. If the patient comes with pelvic vein symptoms, right, then we treat the pelvis first, and then we address the lower extremity. If the patient comes with problems with the lower extremity and nothing on the pelvis, we treat the lower extremity first. If it's in both, then we treat both, always starting from the pelvis.
Thank you so much, Nix, and thank you so much, Lorena. I wish it was me introducing the next expert representative from North America, because she's like family to me and a wonderful professional expertise, but it will be Salvatore Zaza Lazarashvili to introduce the next key opinion leader.
Thank you, Sergio. I want to introduce with great pleasure Dr. Diana Neuhardt, from American Vein and Lymphatic Society, which is, who is, on my opinion, one of the best sonographers in the world. Please, Diana.
Unmute yourself, Diana. Unmute yourself. Unmute yourself. You have to unmute yourself.
I did, yes.
Okay.
Oh, you can tell we're friends. I'm sorry, I was just truly humbled by that comment. But honestly, I'm always humbled when I listen to Professor Labropoulos. We've been friends for years, but Nikos, you have really expanded the role of ultrasound clearly in the pelvis. I think you bring up a good point about the BMI, and I think it's very true in obstruction, a much harder exam, because typically those patients do have an increased BMI, whereas pelvic patients presenting, I know this is true for our category of patients, they're very lean. So actually, we utilize our linear transducers first before we switch to the curvilinear, because I think sometimes you can actually get better images. What are your thoughts about that? I mean, especially about Doppler angles and that.
Yeah, I agree. In our center, for not just for the pelvic disorders, but very often we use the linear transducer to examine patients. For example, for a patient with an EVAR, for an IMA endoleak, most typically we're using actually the linear transducer. And what I do, we start the exam often with a curvilinear, and if the distance is less than 5 centimeters, then we switch to the linear transducer. And why the pelvic exam is important is because the curvilinear has a wide field of view and have, crystals oriented in the different directions. You don't have, steering, and therefore you cannot do good evaluation of reflux. Therefore, with using a curvilinear, you can be very precise about the angles and the reflux and low flow velocities, etc. So for us, it's a big advantage in using the linear transducer very liberally. And currently, just to build on this question, we're doing 3 projects that are almost done. We've developed new criteria for the pelvic veins and been validated with venography. And also we did a new study on the left renal vein, and I can assure you the SMA has very little to do with the obstruction. but we'll discuss that maybe later in the discussion. And then we do on the BMI project. It's very interesting because in order to get this phenomena, you got to be lean in over 90% of the time. Anyway, we can continue on. Sergio.
Thank you so much also, because we could listen to you and Diane for hours. And indeed, I recommend everybody to stop at this CISC center whenever you are flying all the way to New York Venous Symposium to enjoy Diane expertise in person. Now I'd like to introduce the next key opinion leader, who will come all the way from Indonesia. And since it is Indonesia, it's a difficult time zone, for which I will ask Oscar to introduce him, and we are ready to listen to his video.
Thank you, Sergio. Let me introduce Dedi Pratrana, who is the Indonesian leading figure of the Asian Venous Forum.
And here is his question to you, Nikos.
I'm Dedi Pratama, vascular surgeon from Indonesia. Thank you for the excellent presentation. Let me ask you, is there any certain cutoff value for ovarian vein diameter that you routinely use to diagnose pelvic congestion syndrome? And is this cutoff applicable for Asian population, considering that there are considerable differences in venous anatomy compared with Caucasian? And how do you do exactly evaluate the reflux of the intra-abdominal vein only by comparing it to the arterial flow, or is there any maneuver to do? Thank you for your insight.
Thank you, Professor Pratama. And the answer is? Nikos?
I'm sorry, I cannot hear the question. Can you tell me what was the question? I could not hear him.
Oh, okay. So the question was about the cutoff calibers, and if you have any comment about race differences in this perspective.
Sure. For the left ovarian vein, the best cutoff is the 6 millimeters. That will give you probably a predicted value of about 90%. Very few times when there are multiple veins, the diameter is less than 6, and you can find reflex with 4 and 5 millimeters. On the right side, the diameter is absolutely no value, because the vast majority of people with reflux on the left have a diameter of more than 6 millimeters on the right, and the name right is perfectly normal with either venography or ultrasound. And for the rest of the veins, we have criteria only for the pelvic vein tributaries and the periuterine veins, which we decide on our recent paper on SVP to be more than 5 millimeters. In the literature, this is usually around 4 to 5.
And is this applicable to all the races?
So
about the differences between the races. So a Caucasian rather than an Asian.
Yes. Fortunately, this we know because in the US, in New York, mixed population, and our data have African American, many Asian and European, and it seems that there's no difference on this.
Thank you so much, and we thank Professor Pratam. And
only last thing is we have found also that for the pelvic veins, the tributaries, reflux can be present even if the diameter is less than 5 or even sometimes less than 4. But nobody has made a clear association with the diameter and the extent of the veins and the patient's symptoms. But typically, most often these veins are more than 5 millimeters in diameter.
Thank you so much, Nikos. And now we fly from Indonesia all the way to Greece. Again, I wish it was me introducing him. He's a dear friend and a great professional, but it will be Professor Chi. Willie?
Yeah, next we have a dear friend to the VUN Foundation, a leading figure from the Athens University, Dr. Spiros Vestakis.
Hello. Dear friend Nico, I really enjoyed your presentation and I use your protocol of examination. However, there are authors who suggest that the 60 degrees head-up position of the patient gives a better visualization of the vein, and who say also that an increased diameter of the vein has no clinical importance. This is the first question. And if I would like also, if I'm allowed to ask, if the time of the menstrual cycle has any importance of the ovarian vein examination. Thank you.
Spiros, very nice to see you. Long time no see, at least virtually. Very good questions. Yeah, starting with the menstrual cycle, yes, indeed, because usually at that time the patient is more symptomatic, and but the reflux, at least in the pelvic area, is present at that time and outside the time. It makes sometimes difference in females with early reflux in the lower extremity veins, where outside the menstrual, cycle, they may have, normal veins, and then during it, they may have reflux. But that's the exception for the minority of the patients in early vein disease, right? And then now, regarding the position, I agree with you. Typically, we tilt the torso because this allows for better examination. And in fact, sometimes we bring all the way up to 45 degrees. But we make sure that the belly is relaxed. And if this is not sufficient, then we incline the bed almost, at even a higher angle. And then for not for the abdominal exam, but for the perineal exam, then the patient completely stands up, which in my opinion is the best examination and superior to venography, unless if you have a tilting table and the patient is completely standing up on venography and you do select catheterization. If you don't do this, the venography cannot be better than the ultrasound. Thank you, Spiro.
Thank you.
And deeply thank to all the Continental expert representatives who have taken part in this round. So deeply thank you to Lorena Grillo, to Diane Newart, to Dedi Pratama and Professor Vazdeikis. And now we go to the audience, Nikos, and let's see, we've got like more likes, and it is Jose Salas from Latin America, I guess, with a Spanish question. You can read perfectly, but I will translate. The value of the transvaginal ultrasound, how useful it is in the evaluation of the pelvic reflexes.
Very good question. Sergio, we used to do pelvic ultrasound about 15 years ago, but as of 2011, routinely we do the new ultrasound, like they do abdominal transperineal, because it's superior. Transvaginal is good if you don't have experience with transabdominal transperineal ultrasound, because basically show you the presence of varicosities and some of the flow patterns. It's a very useful tool and a very good tool, but if you can do the exam I just saw you, it's just superior, because with the exam I saw you, you can see everything. You can see IVC, iliac veins, ovarian veins, left renal vein, the connection with the extremity itself, etc.
Thank you so much, Nikos. It's a Sunday. Thank you so much for having dedicated these 30 minutes to enlighten us so much. And thanks again to all the ones involved in this first round. And now we move on the way to Singapore. And it is a huge honor for me to introduce not only my squash master, because he's a dear friend with whom we have shared great times, but somebody from whom you can learn so much. Professor Sriram Narayan will tell us about IVUS in pelvic venous disorders, when and what to report. I will ask Khaled to play the video, and then we will go back live to Sriram. Don't fall asleep, Sriram, I know it's late over there. Thank you.
Greetings to all of you from Singapore, and thank you, Sergio, Oscar, and Willie, for your kind invitation for this wonderful project as we discuss the role of IVUS in pelvic venous disorders. The new SVP classification from the AVLS has reclassified pelvic venous disorders based on 4 zones: Zone 1, Zone 2, Zone 3, and Zone 4. And the classification is based on symptoms, venous reservoirs, and pathologies in the different zones. Unfortunately, menorrhagia doesn't seem to be one of the symptoms included, which in my view is an important symptom, but we can discuss that later. So I'm going to demonstrate my change in practice with 2 cases. The first one done in 2018. She was referred to me with typical symptoms of pelvic venous hypertension, and her PCS questionnaire, she scored 3 out of 6. But of note, she had a period that lasted up to 14 days, was heavy with clots and often irregular. She was listed for a transabdominal transvaginal scan to be done immediately after a period that was due shortly. However, she was admitted within a week with severe abdominal pain via the accident and emergency department. A CT scan done at the time was unremarkable, but again of note, there were no adnexal varices or ovarian abnormality or any pathology on the renal vein side that was seen on the CT, which I find is fairly common on a CT done for pelvic venous disorders. A transabdominal transvaginal duplex was done on the 4th of June 2018, and that showed a dilated left ovarian vein at 6.1, dilated adnexal veins with the presence of varices in the pelvis, as well as spontaneous reflux down the left ovarian vein. And that is the report of her left of her transabdominal transvaginal ultrasound. So it was diagnostic of what we thought was pelvic congestion syndrome, and we planned for a left ovarian vein embolization and sclerotherapy. But there are decisions to be made here. She had no hematuria, no leg swelling or varicosity. So was it a renal nutcracker or an NIVL? Balloon-controlled sclerotherapy was planned, but should we do that and embolization or just one or the other? But there was because there was a history of both bleeding and pain. What should be the coil size? The ovarian vein was measured on ultrasound at 1 point at 6.1 millimeters in diameter. Should we be stenting the iliac vein at all? She had normal internal iliac vein flow on the duplex, but that assessment can be difficult if there are very large adnexal veins. And if there were adnexal varices, how should I approach the sclerotherapy? Via the ovarian vein with balloon control or via the iliac veins with balloon control? And that would depend on where the inflection point for reflux was, whether it was in the common iliac vein or a renal nutcracker. So on the left, you can see her still venogram of the left ovarian vein, and on the right, you can see the live venogram done without a Valsalva and with the patient in supine position. And that clearly demonstrates that she has spontaneous reflux down the left ovarian vein with the uterine arcade filling up with large pelvic varices, which were being fed from this ovarian venous reflux. The left picture here shows the IVUS catheter being passed down into the left ovarian vein. And I've put this up to demonstrate that it is quite easy to pass the IVUS catheter right down to the pelvis. And on the right is a live pullback from the pelvis through the ovarian vein, through the renal vein, into the IVC, back out through the common iliac, so that the whole system can be assessed. I'll let that play for you all to have a look at it. And there we are, back in the aortomesenteric angle and back in the IVC. But there were some findings that suggested that she had a nutcracker, but also there were pelvic varices that were seen right at the bottom, as well as the presence of periureteric varices, the significance of which is not quite known in terms of how we should deal with these patients. The aortomesenteric angle compression was quite obvious. You can see the aorta down to the south and the mesenteric artery up in the north as it compresses the left renal vein. There was an over 50% reduction in area of the left renal vein between the normal renal vein and the compressed part on IVUS. One has no idea at this point what is the significance of this compression. But also that the IVUS changed the size of my embolic device because the maximum ovarian diameter that was measured on this was 12.2 millimeters, suggesting a 14 or 15 millimeter device might be needed. There was no measurement done by me in the mid-ovarian vein segment for the balloon control, and that turned out to be a mistake. Of course, the IVUS ruled out an IVL, so there was no stenting that was required in this case. But here you can observe on the left, as the balloon is inflated for control in the left ovarian vein, it goes pop, because I actually ruptured the left ovarian vein during this procedure, as can be seen by the contrast extravasation on the picture on the right. So I was forced, therefore, to not have to do a sclerotherapy, to not then do coil embolization, because the coils might end up inside the peritoneal cavity, and to have to deploy an Amplaxa AVP plug. And this is not easy to deploy in the ovarian vein because it needs a 7 French guiding catheter, which can be a little difficult to get in. In addition to that, there have been reports of ureteric obstruction from these Amplaxa plugs, but I was unfortunately left with no choice. Fortunately, it all went well eventually, and there was no further extravasation of contrast, and she recovered quite well, although there were 1 or 2 hair-raising days observing her. The post-embolization scan did show normal left ovarian and pelvic veins, and her PCS score returned to normal in about 3 months, and she felt like a new woman. But there was much for me to learn from this early case using IVUS. And those lessons have been deployed now in this second case that was done a few months ago, where, of course, IVUS was done before any balloon inflation. She had a normal iliac venogram, and the left ovarian venogram here will show you clear reflux into the ovarian system and across the uterine arcade. The duplex on the left shows you that there was a nutcracker with adnexal and left ovarian vein spontaneous reflux. These are some anatomical stills, so you can see that's the point on the left in the distal left ovarian vein where you would size the embolization device. But there's also a midpoint in the ovarian vein measurement for which would be the size for the over-the-wire Fogarty balloon that I use for balloon control. You can control the diameter of that balloon because there is a straightforward chart that tells you for what volume of inflation, what would be the diameter of the balloon. So that allows you to plan how much to inflate and not to overinflate. These are some anatomical landmarks. On the top left is the renal vein ostium. On the top right is the nutcracker clearly seen at the level of the aortomesenteric angle. And the two bottom pictures show the common iliac vein as well as the NIVL. There is a slight NIVL, but it is less than a 50% compression, and so certainly no intervention for the iliac vein was required. And these live videos now show you the distal ovarian vein IVUS with the pelvic venous reservoir, which you can probably see. I will point it out with the laser pointer here. This is the pelvic venous reservoir with blood flow through it. You can see the renal vein at the aortomesenteric angle compressed. You just about see the uncinate process of the pancreas, the superior mesenteric vein here at about 5 o'clock position, and the aorta above. And on the right is the complete pullback, which we would record as a medical legal procedure. She had balloon-controlled coil embolization and sclerotherapy. On the left is your balloon-controlled venogram. And then this is the foam sclerotherapy. I mixed the contrast along with sodium tetradecyl sulfate in the ratio shown below. This allows me to track the contrast as it passes through. This I find is far more accurate than using volume displacement of contrast, and you're less likely to oversclerose the patient. I then keep the balloon inflated for about 5 minutes, and you can see the distribution of foam while the sclerosant sets itself. And these pictures show you the final outcome of this, the pre-embolization venogram, as well as a near perfect result with antegrade flow down the left ovarian vein. This is done with the balloon slightly deflated. About 50% of the volume is removed to do this venogram. The duplex at 3 months shows no reflux and no variceal filling. So the role of the IVUS in pelvic venous disorders is really evolving, but what it does definitely do is confirm an NIVL or a nutcracker as the primary cause. It also allows you to make measurements of the complete ovarian vein so that you do not overinflate if you're planning a balloon-controlled sclerotherapy, as well as you can size your embolization devices carefully. The IVUS does help you decide which route, therefore, you should use for your sclerotherapy. And of course, if you are planning to stent an NIVL, then an IVUS is mandatory. In addition, if you do find a nutcracker, then it's very unlikely that a right-sided intervention will also be required in such a patient. So in summary, I do believe that the role of IVUS is evolving, but it has become an essential part of my intervention, but patients do need to be consented that the procedure may involve sclerotherapy, embolization, or stenting, but IVUS allows you to make these decisions on the operating table. With that, I thank you for listening, and I look forward to your questions.
And we deeply congratulate Suram for being once again a giant in the field. And we start now with the World Scientific Round. And it is my huge pleasure to introduce Marcelo D'Andro. I still remember when I was in Argentina in 2016, already enjoying his huge expertise on the topic. So it's right that it is him making the key opinion leader question. Marcelo?
Hello, everyone. It's a pleasure for me to participate in POP, and I thank the organization, mainly to Sergio and Oscar, for the invitation. I congratulate Dr. Nayaradan. His lecture was excellent. I agree with the use of the IVUS in pelvic venous disorder. The association with non-thrombotic Ilian lesion and nutcracker syndrome are frequent, and added to the symptoms, the IVUS define the placement or not the stent. My question is related to technique. Why do you prefer the use of the balloon? I ask because its use doesn't prevent the possible complication of the anterograde form diffusion, and retrograde diffusion can be avoided with the Valsalva maneuver at the same time as the infusion. We use local anesthesia, so the patient collaborates with us. The anesthesiologist is waiting just in case. My question is regarding the complications of the balloon on the fact of adding a step. And the second question is in relation to the IVUS and the overestimation. Do you add 20% to the maximum area for the choice of the coil or amplats? Thank you very much for your contribution. They were very helpful for me.
Thank you very much, Marcelo. Question one, why do I use a balloon? It's a comfort zone. I have been doing sclerotherapy for a while, and I've probably seen the whole range of complications from DVTs. I've had transient visual disturbances. I've had some hemiparesis that has lasted for about 2 to 3 days. So I suspect once you've been burnt, you start getting a lot more careful. So I just feel that I have a lot more control with sclerotherapy with the balloon. It doesn't have to be a Fogarty balloon. If you can use angioplasty balloons, but they are much more expensive than a Fogarty balloon. So the other reason for the Fogarty balloon for me is that once the balloon has been put in place, it's not just for the sclerotherapy. All of the coil embolization takes place through that, and the balloon stays in place. So it becomes like my guiding catheter for the rest of the procedure. I just park the balloon and do everything through that. There's no wire exchanges. So it makes the whole procedure much slicker and quicker. Coming to the second question, could you remind me the second question, sir?
Hello?
Yes, the overestimation of the...
Oh, yes. It's about 20%. You're right. It's about 20%. I don't routinely use an amplaxer plug. An amplaxer plug is not easy to get in, and I would like not to use it at any time, is the honest answer. You still need a guiding catheter. But I would oversize the coils by about 20%. But then the coiling also takes place at 2 different levels. Are you coiling the mid-ovarian vein, where sometimes the branching or the bifurcation has ended, or would you be coiling the branches deep down in the pelvis itself? My preference would be to go as distally as possible, because the more proximal the coils extend, the more likelihood that they might extend into the renal vein. So if I can actually deploy 4 or 5 mm coils based on the size deep in the pelvis into the multiple branches, and just one set of coils a little higher up, I would prefer that rather than to have to use bigger coils, because there's some evidence as the coil sizes increases and the vein size increases, the risk of embolization of those coils can also increase. So I prefer to go deeper down.
Thank you so much, Ram. Thank you so much, Marcelo. And now we fly all the way to North America with the introduction of Professor Zaza Lazarashvili.
Yeah, I want to introduce Kathleen Gibson, who is from American Vein and Lymphatic Society, and also active member of International Pelvic Vein Working Group, and one of the experienced doctors in the management of pelvic venous disorders.
And here is her recorded question, Ram, because she's on call.
Thank you for asking me, and I wish I could be here in person. Thank you for the excellent talk, Sriram. I really liked it, and I especially wanted to thank you for using this SVP instrument. And at the beginning of the talk, before you had the IVUS, this patient would have been an S2, symptom 2, V2, varices in the pelvis, pathology, left ovarian vein reflux, non-thrombotic. And what you've added to it with the IVUS was also in the pathology, so it'd be an S2, V2, pathology, left renal vein, obstructive, non-thrombotic as well. So thanks for using that. Traditional imaging often misses pathology, often doesn't show us what we need. Duplex ultrasound adds a lot to that, and IVUS even more. So the value of IVUS is it confirms the diagnosis, it helps you to rule out compressive syndromes and how bad they are, and it helps you with sizing. And then finally, one thing I find it helpful for is finding the orifice of the right ovarian vein, which can be variable. And so my question is, do you routinely interrogate the right ovarian vein, even if it looks normal on duplex imaging? And do you do balloon occlusion venography of the internal iliac veins, either at the beginning or the end of your procedure? And pluses and minuses of different approaches. So I found the right ovarian veins very difficult to get into from the groin. So I've kind of switched approaches and usually go from the neck and can use the IVUS from there as well. But congratulations, and I agree with you that the IVUS is an excellent instrument for patients with pelvic venous disorders.
And we thank so much, Kathy Gibson, and the answer is from you.
Yes, to answer Kathy on her first question, do I routinely interrogate the right ovarian vein? The answer is no, and actually that answer comes a lot from what Nikos presented earlier, which is that you can have a dilated right ovarian vein without spontaneous reflux. I don't mean induced reflux by Valsalva, I mean a spontaneous reflux during an ultrasound. And even if the right ovarian vein is dilated, if it does not show spontaneous reflux, then no, I would not interrogate it. I prefer that, so if I've decided that I'm not going to be interrogating the right ovarian vein, and that decision is made before the procedure starts, because you have the duplex before, then I don't need, although the neck is prepared, but I don't need to go down the jugular route. Coming to the second question, would I do a balloon-controlled internal iliac venography? I don't do any of the diagnostic venographies with balloon control. The balloon is there, but the balloon is deflated. There is no control with the balloon for the venography. And the reason for that is if you do your diagnostic venography with the balloon inflated, you will get spurious results. You will start filling up veins because there is no antegrade flow. So I don't do the balloon-controlled venography, but I certainly do a balloon-controlled sclerotherapy through the internal iliac vein if I find that the pelvic varices are predominantly being fed from an internal iliac reflux and not from an ovarian reflux. But so the balloon control is for the sclerotherapy part. The balloon control is not for the venography part. I hope that answers the question.
It was another lecture. So thank you so much, Ram and Kathy. And now we fly all the way to Germany, and it will be Professor Bottini introduce a dear friend.
Now it's time for me to present Dr. Himan Shalai, one of the biggest experts in the field from Germany and Netherlands, from Aachen University.
Shalai?
Thank you very much for the kind invitation and introduction. Dear Shriram, thank you for the outstanding presentation showing us the usage of IVUS in pelvic venous pathologies. Really interesting. There's no doubt that IVUS is a very important diagnostic tool, and the advantages of IVUS regarding accurate determination of the landing zone and, for example, reducing radiation exposure are absolutely out of question. So I have a question to you and a remark. Would you go for stenting if with IVUS you see an area reduction of slightly over 50%? What if there are no collaterals and a 14 millimeter balloon or 16 millimeter inflated balloon can be pushed and pulled through the pathology? And what if additionally patient symptoms are not really clear? So we should prevent patients from being overtreated by only interpreting IVUS images, as the veins are very dynamic in their anatomical shape and appearance. Thank you.
Thank you so much, Uman, for that question. I assume when you mentioned 14 to 16 mm balloons, you're talking about stenting based on an in the internal iliac iliac veins based on an IVUS finding. The answer is no. I will not stent a patient based on what is the IVUS cross-sectional diameter reduction alone. That can be 50, 60, 80, or even 90%. I would still not stent someone based on the reduction in cross-sectional area. The decision to stent is really made before you go in, and that is based on symptoms.
And so I tend to follow a sort of framework called ABRE, which has nothing to do with the stent itself. ABRE stands, A stands for agony, which is the severity of symptoms. The patient must have symptoms, and some swelling in the leg is not a significant enough symptom. B stands for BMI. Overweight patients or patients with BMI over 30 do better. Patients with low BMI, the stent tends to pain for much longer. So I tend to avoid stenting in low BMI patients. R stands for recurrence. So if they have a primary varicose vein with a chance NIVL that I've seen, then I will not stent them. They need to have recurrence a couple of times before we consider the NIVL to be significant enough. And E stands for eczema, which is skin changes in the legs. So unless they have all this, and you know all of this before you even go into stent, the decision to stent, regardless of the degree of cross-sectional area reduction, is this: I will not stent a patient based on an image.
And thanks so much to Oman and to Ram. And now I wish it was me flying all the way to Kazakhstan virtually, also because I like to recommend the Kazakhstan Venous Forum. That was a great experience I had there. But it will be Professor Willie Chi introducing the next key opinion leader. Willie?
Now we have again a dear friend of the VUN Foundation, leading figure from the Kazakhstan Venous Forum, Professor Askat Sharipov. Askat?
Thank you very much, Sergio, Zaza, Oscar, and Willie, for invitation, introduction, and excellent webinar as always. Thank you very much, Dr. Sriram, for your brilliant presentation, demonstrating a comprehensive diagnostic approach and excellent treatment results. My question is, what is the diagnostic accuracy and reliability of VIVUS in comparison with venography in cases of pelvic varicose? And second question is, in clinics with limited access to such option as IVUS, but with the presence of other diagnostic possibilities, what indication for the use of IVUS would you recommend? Thank you.
Okay, coming to the first question, I don't think IVUS and venography, you can compare the diagnostic accuracy because they're not exclusive of each other. You need to do both. They are part of the same procedure. So to say, I will do a venography as a diagnostic procedure and not an IVUS is probably not right. IVUS, I think, only adds to the venographic part of the procedure when you're actually doing the procedure. So I don't think a direct comparison between the two can be made. I'm certainly not going to do a purely diagnostic IVUS and do interventions in pelvic congestion based purely on the IVUS. Now, if the IVUS is not available, that is understandable. Unlike in iliac vein stenting, although I find a lot of use for IVUS in the ovarian vein, I think it is still evolving. So we can still use the traditional venography ultrasound techniques, but as again Nikos pointed out earlier, please don't rely on CT scans to say yes or no. I do find that CT venography is very, very inaccurate in cases of pelvic venous disorders. So probably a good ultrasound is what one needs.
And thank you so much, Askat. Thank you so much, Professor Holman, Gibson, and Professor Dandalo. And now it's time for the audience. And the one who got more likes is Agila Vacasela Jose Giovanni. Again, I guess from Latin America, in Spanish. Ram, the question is, what is the limit of the BMI for contraindicating a pelvic embolization and surgery of lower limb varices?
Okay, the lower limit of BMI is not for embolization. The lower limit of BMI, which I use at about is for iliac vein stenting, because it is the stent that hurts. In fact, the really low BMI patients tend to do really well with coil embolization. It is the stenting that is a problem that I would like to avoid. As for varices, well, lower limb varices, whatever is the BMI is the BMI. It's just that people who have very high BMI, their recurrence rates are higher. So you have to tell them to try and lose weight if they don't want to come back.
Would you consider that as a limit for surgery and going for endovenous BMI for lower limb or not?
I think the limit for endovenous is not being able to do the endovenous procedure. That's it. Whatever is the BMI. If I can do it endovenously, it will be an endovenous procedure.
Okay. Thank you so much, Ram, and thank you so much for staying up so late and for the outstanding contribution. Now I will try to put myself in trouble, questioning all the audience about pelvic venous disorders and thrombosis, wondering if we are actually underestimating this issue. These are my conflicts of interest, while I declare that I'm indeed interested a lot in this topic, and I've been interested since I read this paper that was published last October by the group of Amin. That is indeed showing something that impressed me. 3% of the women going to the gynecologist, whatever women, every single day, 3% actually presented an incidental uterine venous plexus thrombosis, 3% of all the girls going there. Risk factors have been identified in multiparity with 3 or more pregnancies. And then I started thinking about the literature that is suggesting us that 3 pregnancies could be considered as a risk factor for pelvic venous disorders. So I started wondering if in this population, maybe there was more pelvic venous disorder than what was actually perceived. Recent surgery was presenting an odds ratio of 3.10 that is actually inferior, even if of a small value, to the one associated with the leg varicose veins. That made me think again, because we know from the same masters we have today, Professor Lazzarashvili, Professor Labropoulos, who authored this paper, that 10% of varicose veins at least are not actually having a saphenous origin in the lower limb. So maybe in this population, we could suppose there were like more leaking points than what was eventually identified. We know that lower limb varicose veins is associated with an increased risk of DVT up to 10 times according to the literature. And indeed, we include them in the risk scores for thrombosis. You see, for example, the Caprini and the NICE. So I started wondering if we should add also pelvic varicosities in this kind of risk factors. And indeed, we are also working, it's a true honor and pleasure, with the American Venous Forum, a dedicated committee, to discuss about this and about the importance of the Caprini score. Because as you can see, once again, family history in this population was presenting the highest risk factor. BMI was very low, and we have enjoyed, for example, the data already mentioned by Professor Labropoulos about BMI, and it is something we will discuss about also next week, because we have data, of course, showing us the potential role of obesity in giving us venous hypertension even without chronic venous disease in the background, just because, of course, of the mass action on the hemodynamics. And next week, that will be dedicated to nutrition, we see a very interesting talk by Dr. Maghetti, the special nutritionist, who will indeed talk about BMI again. Postmenopausal status was actually considered a protective factor in this population. And it made me think about those publications that are showing us indeed the role of hormones in the risk of developing eventual thrombosis. If we dissect the paper even more, we will see that this population having incidental uterine venous plexus thrombosis was actually having more pain. And this made me think about those papers that are showing us that pelvic pain is strictly associated, of course, with pelvic venous disorder. And menorrhagia, that was mentioned already today, that could be pathophysiologically associated with the concept of polyglobulia, reactive thrombocytosis, and indeed a prothrombotic state. So many hints and suggestions to have a brainstorming together, I thought. In terms of thrombophilia, in this population by Amin, we were more or less in the range of the other publication reporting about unusual site of thrombosis. And indeed, if we look at the guidelines dedicated to the topic, we see that these are unusual sites, but not so much if we look at specific population, like the one of hysterectomy, that was reporting up to 80% of ovarian venous thrombosis. That made me think about the concept of the venous reservoir that we have in the lower limb that eventually ablated following the hysterectomy could eventually have a hemodynamic role. But of course, we don't have data and we don't have clear recommendation, as you can see from the 2C indication over there. Worthy of note is the fact that we have recommendation, even if extremely low grade, about penile thrombosis. But we don't have, for example, in this document, clear indication about pereuterine venous plexus. that becomes at this point a topic of gender equality, as the same pop design is indeed meant to talk about gender equality. And for this reason, we will finish exactly on Valentine's Day to celebrate both men and females, and in this case, male and females pelvic varices. If we look at pelvic reflux, though, in terms of risk factors, we see that they are not really considered these pelvic venous disorders in the potential risk factor for thrombosis so far. So that we have the amuletic question of anticoagulating or not these patients. And we know that we don't have in reality clear guidelines, despite the complications have been reported to be potentially also high. But first of all, how to diagnose this situation? Because in reality, I was able to find few data specifically addressed to the topic, just some cases series that are not actually really agreeing even on the caliber of these uterine venous plexus, with the 1016 rather than 515, both agreeing though in the fact that it is a difficult topic lacking clear evidence. This is a reading that everybody should perform about the standardized protocol for pelvic venous disorders, we would say now from Nikos and the rest of the team. But even in this very precious reading, we see that we have a limited amount of information about the uterine plexus. And as per the previous publications, mainly focused on the reflexes, not so much on how to diagnose a thrombosis. If we focus on the pathophysiology, I was trying to reproduce a little bit the Virchow triad. Of course, we have also in the pelvic district potential obstruction, reflux, and stagnation. And I found particularly interesting the theory of Malone talking about the stagnation, the hypoxia, the consequent vein wall distension, and the vasovenarum impact that is leading to those leukocytes activations that is really resembling the model of chronic venous disease in the lower limb. And the same Malone indeed was showing in this interesting paper the correlation between thrombosis and venous refluxes, pointing out the importance of an active venous hypertension associated with the pump action. That is, of course, the cuff in the lower limb, but that could be also the Valsalva maneuver at the abdominal level. And indeed, we know that constipation is considered one factor to be taken into consideration in pelvic venous disorder development. In terms of passive venous hypertension, then we are talking about reflexes. And on this topic, we published previously an ex vivo study that was focusing on electron microscopy and on endothelial cell culture, showing interestingly the correlation between hemodynamics parameters and biochemical parameters. And it was very interesting to notice that the reflux time was correlating with the platelet-derived growth factor. That is another factor that is indeed talking about the correlation between refluxes and thrombosis. That indeed, in another publication of our group, showed a normalization after the normalization of the hemodynamics. These hemodynamics are important, as we know, to have a proper functioning of the endothelium lining, a proper shear stress. And we know that the phenomenon is a domino effect that is starting from the microcirculation going to the macro and also vice versa, starting very early with the C0S cases already presenting a decrease in the functional capillary density. So whatever study addressed to the protection of the endothelium lining is of paramount importance, I guess, like this one done in the lab using MPFF, rather than this clinical one showing MPFF role in decreasing the pooling of venous reflexes inside the pelvic circle. But in the topic specifically addressed to thrombosis, another interesting target becomes the glycocalyx, as it was studied in these models of hypertension with the sudodexide, that is acting indeed on a thing we could consider a sort of antenna, this glycocalyx, in honor of Georgia, like the Georgia Broadcasting Tower that I visit thanks to our friend Zaza. This antenna is able to feel the changes in the hemodynamics running on the endothelium lining. And indeed, it has been considered a very interesting target for treatment. And indeed, from Harvard, we had this publication of Raffetto showing how sudodexide acting on that could act on the venous tone, delivering endothelial protection, but also a thromboprophylactic action thanks to dermatan and heparin sulfate. And for this, we really look forward for the results of this investigation of ours on the use of sodexide in the thromboprophylaxis for patients with the lower limb and potentially also pelvic venous disorders. This is another paper that I suggest everyone to read from Professor Kilnani group. It's a consensus document that was pointing out the unmet needs in pelvic venous disorder. And humbly, I would suggest to add also the topics of the related thrombotic risk, and in particular also of the caliber of this vessel and their potential role, in order to properly answer to the call to action that was already made back in 2016 by the NHS on the topic of pelvic venous disorders. I will conclude hoping to have failed you in not giving you more information, but actually giving you more doubts. As Socrates was saying, the more we know, the more we realize how much we don't know. But we know that, of course, we have to develop a teamwork for improving venous disease awareness, and in this case, a particular pelvic venous disorders awareness. And for this, I invite everybody to enjoy an educational questionnaire we created in different languages, of course, including Georgian. You just flag true or false, and you will have the pop-up of the paper that is telling you why it is true or false, and you will also be able to enjoy the raffle prize of a trip to one of the locations of the VWin initiatives. Like in the previous one, they're always pleasant places, like it will be, of course, stunning, the one of Dubai during the Universal Expo. And on the way there, suggest to stop in Georgia, a wonderful place with wonderful people who I deeply thank. And with this, we start from Turkey, another place where we all look forward for going for the UAP 2022, in this case, meeting. It is moved to May, as you know. So Professor Doganji Swat from Ankara University, I'm waiting for your question.
Dear Sergio, thank you for nice invitation for this meeting. And as always, it was a wonderful presentation. The uterine venous plexus thrombosis is one of the missed or unconsidered rare area of venous thrombosis. As you explained clearly, if we do not consider the availability of uterine plexus venous thrombose, it is not possible, I think, to diagnose it. First thing first, we have to keep in mind the possibility of this problem. My question is about the relationship between pelvic congestion syndrome and the uterine plexus venous thrombosis. As I read the article, dilated varicose veins in the pelvis has shown as a possible mechanism for this. However, we have many patients with pelvic congestion syndrome and having larger and huge pelvic venous plexus network. Many of those patients do not face with thrombosis, and many of those are multipart as well. I think there should be some different factors which provokes uterine plexus venous thrombosis. And on the other hand, after embolization procedure, we also partly cause thrombose in the treated veins. And those patients report symptom relief, although they have some thrombosis in the treated area. Do you think symptoms related with the congestion is more prominent than the symptoms caused by thrombosis? Could you comment on those questions, please?
Thank you so much, Swat. You're such an expert. I would ask you to answer reality, because the answer is not easy, but it allows me to quote one of my masters, I would say, Professor Tessari, who was quoting Glauco Bassi, that was a founder of the UAP, who was used to say that the varicose veins are the natural response of our body to venous hypertension. And indeed, I don't see such correlation with venous dilation and pathology. If we think, for example, at the sport paralysis, or if we think, for example, about ulcer patients who usually don't have these huge varicosities, this is an indirect sign to me that the lion is right when he said that if size really matter, then the elephant should be the king of the jungle. In this sense, we understand that it is the biosignaling, in my opinion, that is really making the difference. So the kind of shear stress that is changing on the endothelium lining, that is leading to a reactive inflammatory process. It was nicely described also in a paper by Nikos showing the vicious circle of the venous hypertension. Back to your question about thrombosis, I think about the Takashi Yamaki paper that already years ago was showing us the difference between a sclerosis and a thrombosis. So I think that what you're doing when you're embolizing these patients is far different, of course, from a thrombosis in terms of inflammatory reaction. And in this sense, I would comment that D-dimer indeed is changing in a different way, as we have seen recently with the publication by Connor on the lower limbs. So at the end, I think we just have to investigate more, because there is no answer to your last questions about what is more painful, because we don't have, as Professor Kinnani reported together with all the group in the consensus, a tool that is really allowing us to have objective data collection on the topic. Thank you so much. And look forward for being in Turkey with you for the UAP meeting. And then I will pass the mic to Zaza for introducing the next key opinion leader.
Okay, with great pleasure, I want to introduce Dr. Ayman Fakri from Egypt, who is the leading figure in Egyptian Venous Forum. Please.
Ayman?
Thank you for the introduction. Thank you, Sergio, for this outstanding webinar, and the talk was very great. I like it very much. Thank you for choosing this hot topic. My question for you, despite the high incidence of venous thrombosis in the ovarian vein, as we see up to 80%, treating this with anticoagulation in the literature was very poor, and the recommendation is weak, and the evidence is also weak for treating this thrombosis with anticoagulation. Have you explanation for that? This is my first question. My second question, if you consider IVC filter for such cases, do you think it's better to put it in the suprarenal position, or you still put it infrarenal?
Thank you so much. I think this is a perfect chance to say, see no evil, hear no evil, meaning that if we really don't look at that, we cannot really have the data to answer to these questions. And for this reason, indeed, in the literature, there are contradicting data, and the weak recommendations are actually suggesting in some papers to anticoagulate these patients because the prognosis of this thrombosis was considered potentially an issue. But again, there are no serious data to reply to that. In terms of filter placement, I'm aware of publications that are coming actually from Italy of 10 years ago, actually, showing that there is a safety procedure, of course, in putting up there a filter, but at the same time, I would question if we really need a filter for this case, which I doubt, if there is a proper anticoagulation. And that would be my answer. Thank you so much.
Thanks, Sergio.
And now it will be time for Oscar to introduce the next key opinion.
Thank you, Sergio. It's a pleasure for me to introduce a great friend and an excellent professional who is president of the Society of Angiology and Vascular Surgery of Central American and Caribbean. Andres?
Thank you. Thank you for having me here, Sergio. Do you recommend to perform a magnetic resonance venography in all of those patients who complain of pelvic pain without gynecological reasons?
Absolutely not. And I would like to start thanking you actually for the teamwork we developed in Dominican Republic at the last PIAT mission. Thank you for being here. In reality, I would have doubt even in embolizing them, meaning that according to the literature, and NHS was showing that we still need proper data collection to really justify the embolization. So there is a lot of work to do, I think. I think that the most important take-home message is be aware that there is still an unanswered question on this topic, and be aware that there are papers suggesting that 3% of the girls going to the gynecologist every single day are actually having a thrombosis that would deserve a better risk stratification, as for example, per the Caprini teaching. That's my only goal with today's talk, to raise the question, to start brainstorming on how to have proper data collection. Thank you so much, and change the backdrop. It's too beautiful where you are compared to where we are now. Thank you. And now it will be time for Professor Chi to introduce the last keynote expert representative.
Yeah, we have a very frequent guest of the VWIN Foundation online projects. It represents from the Phlebologist Association of Russia, Professor Igor Zulutukin. Igor?
Hi to everyone. Thank you, Willie. Thank you, Sergio. Thank you, Oscar, for having me here. My question relates to the study of amines on uterine venous plexus thrombosis. It's really interesting study. I downloaded the full text and read it with a great interest. It highlights a really important and rarely discussed problem. And what was surprising for me in amines data is that patients with no pelvic thrombosis had a remarkably low leg varicose veins rates, about 10%, while they were women of mean age of 44. Usually it's about, it should be like 25, 20, 30%. What do you think of this? Is this just a problem of methodology? I mean that varicose veins were underdiagnosed in them, or this may have a kind of fundamental explanation?
I think both, Igor, and thank you for the question. Of course, these stress out the importance of multi-specialty teamwork on the topic, because maybe there is more expertise on thrombosis rather than on clinical aspects. We know that we have to have a proper assessment of these patients to really identify the risk factors. Yet, I think it goes also with the odds ratio they found that is pretty interesting, for which the ones with these incidental thrombosis were actually having significantly more varicose veins. That is leading me back to the paper from Nikos and many others showing us the non-saphenous origin of the lower limb varicosities, for which maybe there was an underestimation of the pelvic venous disorder in this population. So again, we don't have an answer in this, but I think the take-home message is proper data collection in order to be as homogeneous as possible. And we also know the paper by Nyamaki talking about, for example, about post-procedural lower limb chronic venous disease thrombosis, pointing out the difficulty in really assessing the numbers of thrombosis. So maybe just looking at the ultrasound per se is not enough. So risk stratification remains of paramount importance, I would say. Thank you so much, Igor.
Thank you.
And Willie, if you could choose the question for me from the audience.
I'm looking at it. I'm not sure if I'm looking at the right panel, but I
think we were failed by Nikos, who is a good friend of the foundation, and he already replied to all. So you don't see them, but if you go in the one with answer, I promise I will not read the answer of Nikos, but if I'm looking at, I see Javier Cabeza who is a dear friend, and is in the answered questions already. So Nikos is too active. That's the problem we have. It's like too good friend of ours. And so in a patient with a typical varicose veins in the lower limbs and prevalence of pelvic reflux, consider treating reflux first, or if it makes a difference, treating a typical varicose veins. So I'm going to cheat because I can see the answer of Ram, who is a master on the topic. But I will say that we published some minor data on the topic, meaning that together with Professor Tessari and Professor Antignani, we were looking at patients with mild symptoms. So we were using a simple visual analog scale that is, of course, failing us because it's not a proper tool, but it was like a palliation. With the palliation of a VAS with less than 5 as a value, and with no need of doing a further assessment, so basing just on the ultrasound, a lower limb varicose veins treatment by foam sclerotherapy at 4 years was associated with a satisfactory result in 60% of cases. Now, this is very poor quality investigation. So this is just the first step to move forward into proper data collection. I think we are still walking in a field that is too empirical to give an answer. And I wish in the future we'll have proper to answer better. And with this, thank you so much to all the ones involved in this round. We move toward the end. And this is a huge pleasure for us to welcome on stage a person we don't know in the foundation yet, because we indeed invited all the audience to send an evidence-based comment in the previous days, and we selected the 3 best ones. And the best one we selected today is the one from Dr. Mohamed El Naili from Ain Shams University. And we decided to give the topic a title as Pelvic Venous Disorders, Guilty Until Proven Otherwise. here is the presentation, and maybe you understand why we gave this title.
Congratulations.
Good evening, everyone. I'm very honored to have been given this opportunity. I would like to thank Professor Sergio Giannesini. My name is Mohammed Al-Hameli. I'm an interventional radiologist at Ain Shams University, Cairo, Egypt. My presentation today is about a 38-year-old female patient who presented to us with left lower limb pain and swelling. Careful history taking revealed she has also been complaining of deep pelvic pain, dyspareunia, and venous claudication for several months. Her Doppler revealed chronic left iliac vein occlusion and suggested May-Turner syndrome as the underlying cause. This was confirmed by CT venography. Her left common iliac vein is clearly compressed by the right common iliac artery. We took her to the angio suite, and with her lying prone, we got an ipsilateral popliteal vein axis, and as we can see, her left iliac veins are extremely attenuated, with drainage through the contralateral side via collaterals. We were able to cross into the IVC, performed serial balloon dilatation, and placed 2 stents. This is her control, showing restoration of caliber with adequate forward flow and disappearance of the collaterals. Post-operatively, the patient was kept on anticoagulation with rivaroxaban and was instructed to put on compression stockings to increase the inflow through the stents. Thank you very much, and I'm ready to receive your questions.
And we deeply thank Dr. El-Maile, who we welcome on stage. He should be with us. Are you here, Mohammed?
Yes, I'm here.
That is great. We are really happy to have you with us on stage. And
Thank you.
indeed, you have the honor of the honorary question from Professor Bottini. Oscar?
Yes, interesting presentation. Congratulations, Dr. Mohammed. As you know, reporting objective outcome measures is of great importance. Could you expand more on the clinical outcome you had in terms of pelvic symptoms? How you propose to make this symptom report more objective, for example, using the visual analog scale or other scores? Thank you and congratulations again.
Thank you very much. Well, this particular patient, I'm still to see her next Tuesday for her first follow-up, her 2-week follow-up. Technically, I will evaluate the technical success with Doppler. I will check if her iliac veins are, if her stents are still patent. But clinically, which is more important, what was bothering the patient was the pelvic pain. So yes, as you said, the visual analog scale would be a good objective mean to assess the outcome. Her initial pain score was 7 out of 10. We will see, and I hope I will inform you how much did it drop. And also this pain, because this patient, because of the DVT, she had an impending erythema at the gaiters area, which would have probably evolved into an ulcer. So I hope that if this erythema regresses, it would also be a good objective way to assess the outcome.
Thank you, Mohammed. And indeed, the reason why we chose it is because we could talk for like 1 hour about the objective outcome measures. And we know from the publication also of Professor Kinnani that we are missing a proper tool to report that. So that's why there was also the new classification work. So we look forward for meeting you in person in the first chance, hopefully also in Egypt. And now it's time to wrap up. So we invite our honorary chairs, starting from Professor Urbanek from Silesia University, telling us what we should take home from this webinar. Thomas?
Good afternoon. It's honor for me to be here. We had these 3 wonderful talks and also interesting discussions. And already from the first talk, we see that there is plenty of things to do. Yesterday, in Journal of Vascular Surgery, Veins and Lymphatic, the SVP classification was published. It's available online starting from yesterday. So I think it's a good and expected step towards further research on pelvic venous disease. And as we saw in Nico's talk, we need the standardization. We need the standardization of the diagnostics, like transabdominal ultrasound. Probably the same will be about transvaginal, and also standardization about the patient qualification and treatment. So I think that this is a wonderful opportunity that right now we can talk about the same, using the same classification. However, we need also the tool to assess the quality of life and the patient's symptoms. Sriram mentioned about the use of IVUS in this particular situation. It's a really great idea. Many of us use IVUS, but I personally never use IVUS for renal vein diagnosis and ovarian vein embolization. So I think having such an opportunity, if we have such a patient, it's worth to think about this, that we can expand and increase our opportunities to treat the patient safe and good way, using this kind of stuff. And Sergio, you touched the topic that is completely new. We have no guidelines, no data, and we need a lot of research and reports about this. And I encourage all of you to report on these patients, because there is no guidelines available regarding this topic. We have just the guidelines on pelvic veins and mesenteric vein thrombosis, but the rest is unknown and plenty of things to do. Thank you very much, and congratulations for this wonderful meeting.
Thank you so much, Thomas, for being such a good honorary chair. And then another excellent honorary chair, all the way from Netherlands, the European College of Phlebology representative, Professor Wittens. Cheese.
Yes, hello. Also, thank you for the opportunity to discuss this. Well, I think the first point I want to stress again is that everybody who's trying to get into this area should be aware of all the anatomy and pathophysiology. And we can talk about duplex and all kinds of diagnostics, but in my opinion, a lot of people don't really understand the hemodynamics in the pelvic area. And it's crucial that before you start diagnosing or treating it, that you are aware of the anatomy and the pathophysiology. And I think that Nikos alluded that. And of course, we don't know too much about it. And I'm very happy that under guidance from Mark Meissner, we are trying to get that new scoring system, although it's extremely cumbersome. And I don't think it will be used in practice because it's too cumbersome, but it's scientifically, it's very valuable. And I hope that it will help us to make better choices in treatments and choices in follow-up and how to select patients for certain treatments. In general, and that's also alluded already by Nikos, that if you have a patient with only leg symptoms, don't treat, although it's coming from pelvic area, just treat the varicose veins. If they have pelvic complaints, then or a combination, then we should start with the pelvic problems. And then, in my opinion, you will always have to start with treating obstructions, and then later, if that has been treated, you treat the incompetence. I was a little bit afraid of the talk of Sriram about IVUS because it is about 2 cases, and you might go home with the feeling that this is a tool which we always have to use. We haven't got a clue what the value of it is. We have a lot of diagnostics. It might be additive a little bit if you are in doubt, but it will never tell you which patient is selected for an obstruction. Those studies are done in supine position. If you put them upright, most of the time those stenosis which you identify will just disappear. That's also why the duplex is done in a standing situation, or at least in the 45 degrees. And the last thing, although we are doing a lot, and it's I'm very thankful for putting this on the agenda, is that unfortunately 30 to 40% of the patients that we treat, they don't get better. They still have the same complaints, probably do wrong diagnostics or wrong treatments or whatever we do, but we are not very successful. And then the 60%, which is already very, very good. If they are successful, unfortunately, in half of them within a few years have new complaints. And probably due to the fact that blood has to go somewhere. So it grunts for a new route, and it finds new dilated veins or new obstructed outflow tracts, and they have new complaints. So we have to look into it very thoroughly again. So it's an important area with a lot of patients who complain about it, but we are not very successful yet in selecting the right ones and to select the right treatment. And that's my, let's say, take-home message. Thank you.
Thank you so much, Cheese, Professor Wittens. Now, since we are enjoying this educational walk together with the Georgian friends and colleagues, it will be Professor Zaza Lazarashvili introducing the honorary chair for her wrap-up.
Yeah, thank you, Sergio. I want to introduce Professor Tudana Gachichiladze, who is the member of Georgian Academy of Medical Sciences and leading ultrasound specialist in vascular field, and also my very old friend, but she is not old, I am old.
Okay, so here is a wrap-up.
Dear Sergio and dear Zaza, thank you for great opportunity to participate such interesting essential webinar. Pelvic congestion syndrome seems to be misunderstood and often undiagnostic cause of chronic pelvic pain. Nowadays, different imaging modalities adhere to different diagnostic criteria for pelvic vein abnormalities and varicosities. Doppler ultrasound is usually the first-line imaging modality in patients with suspected pelvic venous disorders. So Dr. Labropoulos has the brilliant presentation of protocol for transabdominal ultrasound examination of pelvic venous disorders, which is very accurate and detailed. Also, both transabdominal and transvaginal ultrasound for the pelvic veins and the lower limbs vein ultrasound must be used. Presentation of Professor Sirnar Narayanan is great importance for interventional specialists. His experience in use of intravascular ultrasound in pelvic veins disorders diagnostic is valuable. Professor Narayanan broadly describes prevalence of intravascular ultrasound in venous disorders diagnostics, its tips and tricks, accuracy of IVAS, instant sizing, landing zone assessing, and etc. Hope intravascular ultrasound will be used more widely in pelvic vein disorder care. Another great significance of all non-invasive diagnostic tools as ultrasound, multi-detector CT angiography or MR angiography is to accurate diagnostics of pelvic venous thrombosis, because to its relationship with such dangerous complication as acute pulmonary thromboembolism. Pelvic venous thrombosis often is misdiagnosed by routine ultrasound examination. Today we had excellent lectures of Sergio Gianesini on this topic. Presentation is very helpful and important for practical doctors and especially radiologists to be careful and attentive with pelvic venous thrombosis diagnostic. In conclusion, I want to say a couple words about this project. POP, from my point of view, is very important educational project which gives opportunity to share your experience with leading specialists from whole world. Project is with great success and future. Thank you all once more, board and attendees, for such big pleasure.
And we deeply thank Professor Gachichiladze. I am getting better with my Georgian pronunciation. I'd like to have Professor Bottini to say a final word, and then Willie. Oscar, final remarks? Willie?
Thank you, everybody. See you next week.
Thank you so much. And now we fly all the way to our project leader. So Zaza, Salvatore.
Thank you to all participants and the faculty, and wait to again to see you on next week. Bye.
Thank you so much. Oscar, are you back? Okay, so we move forward, deeply thanking everybody who joined today, particularly the stellar faculty. Once again, thank for the unbiased support to Alpha Sigma for making this possible. We look forward for being together in person as soon as possible. Until then, let's see you next Sunday. Thank you so much and see you next Sunday. Bye. Ciao.